Now let us talk about the ulcer disease in stomach. Now there can be acute ulcers in stomach. There can be a chronic ulcers in stomach. Now let us first talk about acute ulcerations. What can you tell me? What is the most common cause of acute ulcerations in stomach? Acute की बात कर रहा हूँ. It is stress gastritis. The most common cause of acute ulcerations in stomach is stress gastritis, and stress gastritis can happen because of various reasons. Stress gastritis can happen because of various reasons, like hypotension can lead to stress gastritis, like head injury can lead to stress gastritis, and this head injury leading to stress gastritis and leading to ulcers in stomach, those ulcers are called Cushing ulcers. There can be stress ulcers due to burns also, and the stress ulcer due to burns are called curling ulcers. Now, when I was even today, not at your level, I was even today sometimes get confused. Cushing ulcer in head injury or Cushing ulcer in burn, curling ulcer in burn or curling ulcer in head injury. So I used to get majorly confused, and as I told you, I am very bad at mnemonics. मैंने बहुत बार कोशिश करी mnemonics बनाने की. लोग mnemonics बनाते हैं, बड़े अच्छे से याद भी रह जाता है उनको. मेरे को कभी mnemonics बनाए, कभी ये भूल गया ये किसका mnemonic है. इतने सारे बन गए, पता नहीं कौन किसका है. और कितनी बार ये भूल गया कि इस निमोनिक का फुल फॉर्म क्या है, तो मैंने निमोनिक बनाना ही छोड़ दिया. But this confusion was a major confusion for me, and I made out a solution for this, a very cheap kind of solution, but a very good solution. It works for me. बहुत ही चिल्ला टाइप का है, but काम करता है मेरे लिए. R of curling, R of burn. So burn, ये बहुत कंफ्यूजन होता है, एग्जाम में होगा. तो अगर ये क्वेश्चन आए तो मुझे याद करना कि कर्लिंग R, burn, ठीक है. So and another very important point is the most common site of all these stress ulcers. Important point. The most common site, your MCQ sources have a wrong information. This is the latest here now. The most common site of all the stress ulcers is fundus of the stomach. It can go to the body of the stomach also. These ulcers can go to the body of the stomach also. But very important point for us to note, curling ulcer is the only type of stress ulcer which can reach first part of duodenum also. So if a question comes, what is the most common site of curling ulcer? It will remain fundus though, but curling ulcer is the only type of stress ulcer which can reach first part of duodenum also. One should know. Now coming on to the chronic ulcers. In chronic ulcers, we have an ulcer in the stomach that is called gastric ulcer. We have an ulcer in the duodenum, which is called a duodenal ulcer. Now, can you tell me, again, a very commonly asked question, what is the most common cause of duodenal ulcer? The most common cause of duodenal ulcer is H. pylori. Now, can you tell me what is the most common cause of gastric ulcer?
H. pylori.
It is H. pylori here also. And the second common cause in both is again NSAIDs. And out of gastric ulcer and duodenal ulcer, which ulcer is more common?
Duodenal ulcer.
Duodenal ulcers are more common than a gastric ulcer. Now, another important point, there is some blood group which is also associated with ulcer disease. First of all, which blood group and which ulcer it is associated with? It is blood group O. Blood group O is associated with duodenal ulcers. Important point. Now, can you tell me what is the most common site of duodenal ulcer? Most common site of duodenal ulcer is duodenum. ये ठीक है यार. First part of duodenum. First part of duodenum. ये वैसा ही हो गया जैसे मेरे पास एक पेशेंट आया उस दिन ओपीडी में, मैंने पूछा क्या हुआ है, तो सर ये तो आप बताओगे. बात भी सही है, मैं बताऊंगा. So first part of duodenum. The most common site of gastric ulcer is lesser curve incisura angularis. कभी कभी ओपीडी में ना बहुत फनी चीजें होती हैं, इमरजेंसी में भी होती हैं. तो एक दिन हमारे पास एक पेशेंट आया इमरजेंसी में, होता है सब बहुत दर्द हो रहा है, बहुत दर्द हो रहा है. हमने कहा हाँ लेटो 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 जल्दी लेटो. तो सर मेरे नहीं मतलब एक पेशेंट आया ओपीडी में एंड उस दिन सब यूजीज और पीजी भी थे, इंटर्न्स भी थे और बीपीएच का केस था. हम बात करेंगे. तो आई थॉट कि पेरेक्टल एग्जामिनेशन बताते हैं इनको कि हाउ टू डू अ पेरेक्टल एग्जामिनेशन. सो I told them that this is how we do DRE, digital rectal examination, this is how we do proctoscopy. तो ये सब कह के मैं अपना आ गया, पेशेंट देखने लग गया, अपना कर्टन के पीछे सब मैंने बता दिया पेशेंट को लेटा के, और अब मैं आके अपना पेशेंट देख रहा हूँ. थोड़ी देर बाद, एंड इट वाज वेरी एम्बैरेसिंग फॉर मी एक्चुअली, थोड़ी देर बाद पेशेंट कर्टन से बाहर आता है गुस्से में कि मेरे पेपर दो. क्या हुआ? मेरे पेपर दो. नहीं हुआ क्या? अगर यही इलाज है तो घर पे करा लूंगा. मैंने देखा कि सारे के सारे एक हाथ में ग्लव पहने तैयार कर दो. ग्लव वाला पैक में वो ग्लव खत्म हो गए, सारे एक हाथ में. एंड इट वाज माय मिस्टेक. आई शुड हैव टोल्ड देम कि एक दो ही करना. So coming back, now in a peptic ulcer disease, I will be talking about the surgical aspect of peptic ulcer disease. I will not be talking about the medicinal part of peptic ulcer disease, that how we diagnose peptic ulcers, what is a urea breath test and all those urease test and all. I will not be discussing. I will be talking about the surgical part. And this also holds true, and this was also one of the question in exam, that the role of surgeons in a peptic ulcer disease is declining. There was a question asked that why the role of surgeons in peptic ulcer disease is decreasing. The reason for lesser surgical intervention in peptic ulcer disease is since the time we have a proton pump inhibitors with us, very less occasion comes where we have to do a surgical intervention. So there are only two indications of surgery. There are only two indications of surgery in peptic ulcer disease. Now, what are those indications? One indication of surgery in peptic ulcer disease is when there is a intractable peptic ulcer disease. Whenever there is a intractable, what is intractable disease?
Not responding to.
Intractable term is used for those conditions which stops responding to any form of medical therapy. When a disease stops responding to any form of medical therapy, it is called intractable disease. And the second indication of surgery in peptic ulcer disease is when there are complications due to peptic ulcer disease. These are the two specific indications of surgery in peptic ulcer disease. Now, what surgery are we going to do in a particular ulcer disease? In a duodenal ulcer, very commonly asked question it is, the surgery of choice. Surgery of choice in a duodenal ulcers is highly selective vagotomy, which is also called or parietal cell vagotomy, which is also called parietal cell vagotomy. And very, very important point to note in this surgery, nerve of Letarget's. You know what a nerve of Letarget's now? Are preserved. And very important to know, nerve of Grassi should always be divided. Nerve of Grassi should always be divided, or one can also say, or in this surgery, proximal two-third terminal branches of vagus nerve are divided. The distal one-third branches are spared. Nerve of Letarget's or distal one-third branches are spared or preserved. This surgery is a surgery of choice, but this surgery has a high recurrence rate, but very less morbidity it has. This surgery has a high recurrence rate, but having a less morbidity, a question asked. But if you are asked what is the best surgery for a duodenal ulcer, best surgery for duodenal ulcer, if asked, it is truncal vagotomy with entrectomy. The best surgery for a duodenal ulcer is truncal vagotomy with entrectomy. This surgery has a least recurrence rate, but has high morbidity. This surgery has a least recurrence rate, but has a high morbidity, because once you remove antrum of the stomach, you can appreciate that either you have to do Billroth 2 or you have to do Roux and Y procedure. And there is a set of complications with all these procedures. So morbidity is more. Okay. Then comes for gastric ulcer. The surgery of choice for gastric ulcer is distal gastrectomy. surgery of choice for gastric ulcer is distal gastrectomy. What is distal gastrectomy? Say for example, this is the stomach and here lies the ulcer. What is distal gastrectomy? When we remove the ulcer bearing part of the stomach and distal to that. Whenever we remove the ulcer bearing part of the stomach and distal to that, it is called distal gastrectomy. Ulcer wale part se leke distal part of the stomach once we remove, that is called distal gastrectomy. Okay. So this is the surgery of choice for a gastric ulcer. Now can you tell me, out of duodenal ulcer and gastric ulcer, which ulcer is more common? Duodenal ulcers are more common. So most of the time, when we talk about an ulcer disease in stomach, we talk about duodenal ulcer actually, right? Now, can you tell me what is the most common complication of peptic ulcers? The most common complication is bleeding. Very good. Followed by perforation. Followed by goo. Gastric outlet obstruction. Gastric outlet obstruction. Right? So now, most common complication is bleeding, followed by perforation, followed by gastric outlet obstruction. Now, let us first talk about perforation. We will first be talking about the perforation, then we'll talk about bleeding as a complication. How we go about, what are the various things in bleeding and perforation, let us know. It is said that, important point, anterior ulcers perforates, posterior ulcers bleeds. So if the ulcer is on the anterior side of stomach or duodenum, it will perforate. But if the ulcer is on the posterior wall of the duodenum or the stomach, it will bleed. Okay, so we are talking about a perforation here, and duodenal ulcers are more common than gastric ulcer. So when we talk about a perforation, we most of the time talking about a duodenal ulcer perforation. Now this is the duodenum. Please understand this, what we are going to talk about. देखो ये understanding है. If you understand this, then only you will be able to understand the clinical profile of the patient in a given clinical question, right? So this understanding is must for our understanding of a GI conditions, not only for duodenal ulcer perforation, for any GI condition also, right? How? You'll see here. Imagine this is stomach. And there is an ulcer here, which got perforated. Now, what do you expect will happen to this patient? How this patient is going to present to you? What will be the presentation of this patient? Can you make out? Patient will come to us when the ulcer has perforated. Patient will come to us with a severe, generalized, continuous type of stabbing pain in abdomen. What else you think the patient will have? When the ulcer perforates, posterior ulcer bleeds, anterior ulcer perforates. तुरंत आ गया. Patient won't say that I have ascites. पेशेंट को क्या प्रॉब्लम होगी? भारी भारी लगेगा, भारी हो गया अचानक से। क्यों भारी क्यों हो जाएगा? भारी क्यों होगा? असाइटिस होगा तो भारी हो जाएगा। असाइटिस तो जो इंटेस्टाइन के कंटेंट ही तो बाहर आए हैं, और वो इंटेस्टाइन में थे तब भी उतना ही भार था उनका, बाहर आए तब भी उतना ही भार है, तो भारी क्यों हो जाएगा? वॉमिटिंग होगी, वेरी गुड, वॉमिटिंग होगी, और क्या होगा? When the contents are going to leak out, the abdomen will distend also. So patient will complain of abdominal distension also. Patient will say that my abdomen got distended. Then what else the patient will have? Symptom. Tenderness is a sign. Patient will have obstipation also. What is obstipation? No feces, no flatus. No feces, no flatus. If the patient is not passing flatus and motion, it is called obstipation. Patient will stop passing flatus and motion. Right? My resident, like the way she said, used to say that patient is not passing fetus and feces. अब flatus बताऊं क्या होता है? Demonstrate करने का मत बोलना। So patient will present with these symptoms. अब मुझे ये बताओ, सोच के, पेशेंट का अगर duodenum परफोरेट हुआ तो ये साइंस आ रहे हैं, ये सिम्टम्स आ रहे हैं। अगर ileum परफोरेट होगा, what symptoms will be there? Same symptoms. If colon perforates, then also will be the same symptoms. Sorry. तो कैसे पता लगे? How will we know that this symptom which the patient has come to us with is probably having a duodenal ulcer which got perforated? कैसे पता लगेगा? On the basis of symptom, this understanding, देखो ये I am trying to make you understand the given clinical profile. So how on the basis of symptoms we will make out that probably this is something to do with the duodenal ulcer perforation. See, okay. Now, when the duodenum perforates, duodenum lies in the epigastrium, right? So the content will leak first in the epigastrium. सबसे पहले the contents will come into the Morrison's pouch. Whatever the secretions are there in the duodenum will come into the Morrison's pouch, and then those secretions will go to the right paracolic gutter. धीरे-धीरे the Morrison pouch will get filled with the collection. All the secretions from the duodenum will come into the Morrison's pouch. Are you understanding what is Morrison pouch? You know, yes. Right? And then all the collections, the hepatorenal space. There is a cavity in the abdomen which is called hepatorenal space. एक potential space है stomach, the liver और kidney के बीच में. So all the collections will come and get collected there. So जब ये पूरा का पूरा Morrison's pouch भर गया, तो obviously it will spill. So it will spill its collection to the right paracolic gutter. On the side of the colon, there is a potential space which is called right paracolic gutter. So सबसे पहले वहां पे जाके collection Morrison's pouch से वहां आ जाएंगे. फिर जब वो भर जाएगा, तो ये collection pelvis में चले जाएंगे. Right? When pelvis get filled with this collection, the collection will go into the left paracolic gutter. Right? And when the left paracolic gutter get filled, it will come to the splenorenal space also. So that means now whole abdomen has a collection. Understood? But how the collection is going? First to the Morrison's pouch, then to the right paracolic gutter, then the pelvis, and then. Now, is abdomen used to duodenal contents? Is the peritoneum used to a duodenal contents? No. So when the duodenal contents comes into the peritoneum, inside the peritoneum will get inflamed, right? So when the inflammation of peritoneum happens, what is that called? So that means this problem will lead to peritonitis. So that means whenever there is a ileum perforating, whenever colon perforating, whenever blood comes into the peritoneal cavity, whenever bile comes into the peritoneal cavity, with these things the peritoneum is not used to. So what will happen to the peritoneum? Peritoneum gets inflamed, so it leads to peritonitis. Understanding what important understanding I'm trying to give you, because the kind of questions are not going to be direct to you. So in a peptic ulcer perforation, you can agree now that the patient will have a peritonitis. Even a ileal perforation will have a peritonitis, even a colonic perforation has a peritonitis, even a hemoperitoneum will have in the peritoneum, then also there will be peritonitis. तो अब पता कैसे लगे कि ये जो peritonitis के symptom है patient को, they are actually because of ileal perforation or a cecal perforation or a duodenal perforation. So correct me if I'm wrong. This patient presentation, patient has a severe generalized continuous type of stabbing pain in abdomen happening, but it will not be this at the time of presentation. It will start with, where will the pain first be? The pain first be in the epigastric region. Patient will have a pain in the epigastrium first, the severe pain in the epigastric region, and then gradually the patient will say, my pain has now become generalized. Now I can't make out where the pain is because it is happening all over the abdomen. But if you ask this patient where the pain was started, the patient will say, my pain started in the epigastric region. So the pain starting in the epigastric region and then getting generalized. One should always think of two things. Remember as a rule, any patient once comes to you with a pain starting in the epigastric region and then getting generalized and giving you features of peritonitis, one should always think of two things. One, peptic ulcer perforation, and second, pancreatitis. Any patient, remember as a rule, you will be checked on this. So you have to understand that any patient once comes to you with a pain epigastric region and then giving you features of peritonitis, you should always consider two things. One, peptic ulcer perforation, and second is pancreatitis. Now, how will we know that it's a peptic ulcer perforation? We are going to talk about here. How will we know it's a pancreatitis? We'll talk about in pancreas. So let's assume that a patient who is coming to us with a pain epigastric region and then giving us a features of peritonitis, we have to rule out only one thing, that is peptic ulcer perforation in this discussion. But there we have to rule out two things. Okay, so now correct me if I'm wrong. On examination of this patient, what are the signs? There will be, when you touch abdomen, the patient peritoneum is inflamed. So patient will have a tenderness. Right? Patient will have a tenderness. Patient will have guarding. Patient will have rigidity also. Now what is guarding and what is rigidity? Guarding is an involuntary response. Guarding is a voluntary response and rigidity is an involuntary thing. What is guarding and what is rigidity? Now what happens is the peritoneum got inflamed, right? And moment you touch peritoneum is a very sensitive structure. So moment you put a hand on the abdomen, the hand pressure will go from the skin to the muscle, from the muscle to the peritoneum. So patient will have a tenderness. So what body tries to do, To avoid this tenderness, the moment you put a hand, the muscles goes in spasm. The moment the muscle goes in spasm, it prevents the tone of the muscle increases, so it prevents the muscle to touch the peritoneum. So this is called guarding. So moment you touch abdomen, the muscles will go in spasm, which is called guarding, right? Now, since the peritoneum got inflamed for long duration, so body knows that there will be a problem if somebody is going to touch. So these muscles goes in persistent spasm. So this persistent spasm of the muscle which happens is called rigidity. So guarding happens before rigidity, but eventually in a peritonitis, long-standing case of peritonitis, there will be a board-like rigidity because the body doesn't want the peritoneum to get anything to impinge on peritoneum. So there will be tenderness, there will be guarding, there will be rigidity. Now you know these are not the signs specific to a peptic ulcer perforation. These are the signs of peritonitis. So any patient who has a peritonitis will have these points. Now please understand this point. As this problem is gradually coming up, as this problem is gradually setting up, please appreciate this. Initially, the patient will have a tenderness in the epigastrium and right hypochondrium. Yes or no?
Yes.
Yes or no?
Yes.
Then this is called localized guarding and rigidity. Initially, there will be localized guarding at the right hypochondrium and epigastrium. Then gradually this guarding will shift to the right iliac fossa. And then over a period of time, it will be all over the abdomen. So what happens in peritonitis? Initially, there is a localized peritonitis. The local site of the peritoneum get inflamed, then whole peritoneum get inflamed. When the whole peritoneum get inflamed, it is called generalized peritonitis. When a particular part of the peritoneum get inflamed, it is called localized peritonitis. So in a patient of a peptic ulcer perforation, on examination, if the patient comes to you in an early stage, there will be a tenderness and guarding more in the epigastrium and the right hypochondrium, and then it will be generalized. Agreed? So this patient is going to present to us with these features. Okay, so on the basis of patient's profile, we can make out what could be the reason of a particular patient's peritonitis. Now, since this patient profile is such that the pain started in the epigastric region and then got generalized and giving us a features of peritonitis, we know that we have to rule out two things: peptic ulcer perforation and a tenderness. But here we are just thinking at that it is a peptic ulcer perforation. Now, correct me if I'm wrong. Can I say that it is an acute infective GI condition?
Yes, sir. Yes.
Yes or no?
Yes.
It is an acute infective GI condition, and we know that in any acute infective GI condition, we have to first immediately keep the patient nilparorally, start IV fluids, IV broad spectrum antibiotic, and IV anti-inflammatory drugs. So immediately we will start this. Now, how will I know that there is a peptic ulcer which got perforated? See, please understand, peritonitis can have multiple reasons. I made you understand that if bile comes in the peritoneum, there can be peritonitis. If blood comes in the peritoneum, then also there will be peritonitis. If ileum perforates, then also there will be peritonitis. If colon perforates, then also there. So there are many causes of peritonitis that means. So in a particular patient of peritonitis, the first line of management remains the same because it's an acute infective GI condition, right? Now, in a particular case of peritonitis, ये understanding वाली बात है, अगर bouncer जाए तो मुझे बोलना, right? So, in any case of peritonitis, we have to start this. But in a patient of peritonitis, our first investigation will be on the basis of that particular problem whose suspicion will have as a first diagnosis. So, since this particular patient of peritonitis has a pain started in the epigastric region and then got generalized, I have a suspicion of a peptic ulcer perforation. So, my first investigation will be towards a peptic ulcer perforation. So, what I am trying to convey through this is that our first investigation in any patient of peritonitis may vary depending on what suspicion I have for that particular peritonitis. Now, since in this peritonitis I have a suspicion of a peptic ulcer perforation, I will direct my investigation for a peptic ulcer perforation. And what that investigation be? Once a peptic ulcer perforates, you can appreciate not only the content will leak out, but also gas in the which is there in the intestinal lumen will leak out. And gas has a property to ascend up. And gas is not there in the peritoneum. In a normal individual, the gas is not there. So in a peptic ulcer perforation, we will find a gas under the dome of a diaphragm. So if we find a free gas under the dome of diaphragm, our suspicion of a peptic ulcer perforation will be. So what investigation I should do to see a gas under the dome of diaphragm? Chest X-ray. I should do a chest X-ray. So the investigation of choice for pneumoperitoneum, if asked, this will be pneumoperitoneum. Presence of air in the peritoneum is pneumoperitoneum. So investigation of choice for pneumoperitoneum, if asked, it will be chest X-ray. If chest X-ray is not in your choice, then it is X-ray abdomen. Right? And if you are asked what is the most sensitive investigation for pneumoperitoneum, it will be CT scan. CT scan, when we say, it is always contrastive. Right? So it is CT scan as a most sensitive investigation. Now, once in a patient of a peptic ulcer, we have a patient coming to us with this problem. We have already started this. We had a suspicion of a duodenal or peptic ulcer perforation. We did chest X-ray and we found a gas under the dome of diaphragm. So once we found a gas under the dome of diaphragm, our suspicion of peptic ulcer perforation is confirmed. So in a peptic ulcer perforation, there is no way we can treat it conservatively. Esophageal perforation, we had a situation where we managed them conservatively also, I told you. But in a peptic ulcer perforation, we never do a conservative management. So our next line of management will be exploratory laparotomy. We will open abdomen. We will open abdomen and we will suture duodenum by putting a loop of omentum over the whole of duodenum and then applying the sutures. And when you support, duodenum also doesn't have a serosa. So when you support the whole of duodenum with omentum, this is called buttressing of the duodenal hole. And this buttressing of the duodenal hole with omentum is called modified Graham's patch repair. This is called modified Graham's patch repair. So that means if a question comes to you, what is the treatment of choice for a duodenal ulcer perforation? Your answer will be exploratory laparotomy with a modified Graham's patch repair. But if the question comes to you, what is the first line of management in a duodenal ulcer perforation? Your answer will be keeping the patient infraorally, IV fluid, IV antibiotic and IV anti-inflammatory drugs. So this is how we are going to manage a peptic ulcer perforation. Right now, then comes bleeding. Now we are going to talk about bleeding in a common heading of hematemesis. This discussion which we are going to have is a very, very important discussion. And when I was at your level, I had this gross confusion. Okay, now first of all, let me tell you the theoretical points in this. Let me finish off with the theoretical points. Then I will make you understand the situation. Okay, the most common cause of hematemesis Most common cause of hematemesis is lower GI bleed. ये क्या बात थी भाई? Is upper GI bleed. Most common cause in upper GI bleed or hematemesis is peptic ulcer disease. Duodenal ulcer more common than a gastric ulcer, followed by esophageal varices, followed by gastric erosion, and followed by Mallory Tear. Most common vessel which bleeds in duodenal ulcer bleeding is gastroduodenal artery. Most common vessel which bleeds in a duodenal ulcer bleeding is gastroduodenal artery. In a gastric ulcer bleeding, it is a left gastric artery. Okay, now let us understand this. Listen to this part very carefully, because again you will have a clinical question with you on this, and this question very commonly asked, because these patients we very commonly come across in emergency also. So all those emergency things you all should be well versed with. Okay, now just hold it. Hello. किसी ने कोई खास बात करते हैं, सब ठीक है ना? Okay, now this confusion most of us have, and this confusion now we have to get rid of. The most common cause of hematemesis is peptic ulcer disease. Okay, listen to this, what I am going to tell you. First of all, can you tell me what is the most common cause of hematemesis in chronic alcoholic? Esophageal varices. Absolutely wrong. The most common cause of hematemesis in chronic alcoholics also is peptic ulcer disease. Remember, most common cause of hematemesis in a chronic alcoholics also is peptic ulcer disease. Okay, now listen to what I am going to tell you. Chronic alcoholics must have been discussed in your medicine classes, can have varices also because of portal hypertension. Yes or no? Yes. So that means chronic alcoholics can have hematemesis because of varices also, right? So when should we consider varices as the most common cause of hematemesis in chronic alcoholics? Listen to this, because our approach in a given patient of hematemesis, what is hematemesis? Blood and vomiting. So our approach in any given patient of hematemesis depends on what suspicion we are having, right? So how should we have a suspicion of a variceal bleeding? What clinical profile of the patient will be there in a given question, which will make us think that probably this hematemesis is happening because of varices. So if in any given question you are told that the patient is chronic alcoholic, And along with this chronic alcoholic history, if any of these six things are there, any of these six things are there, if this patient is coming to you with hematemesis, you should think of varices as a reason and manage this patient according to variceal management. What is that variceal management? We will understand, right? So, what are those six things? If you are told that there is ascites, chronic alcoholic with ascites coming to you with hematemesis, think of varices. Chronic alcoholic with gross splenomegaly, gross splenomegaly. Chronic alcoholic with caput medusae. You know what is caput medusae? Chronic alcoholic with spider angiomas. Chronic alcoholic with Palmer erythema. Chronic alcoholic with encephalopathy. If any of these six are there, we should manage, we should start management as if we are managing a varices. In rest all other cases, listen to this information. In rest all other cases, our management will be this, which I am going to now talk about. So what is a variceal management? We will discuss after this. But what is a management in hematemesis other than these patients? We are going to talk about now. So in all other patients, listen to this point first. In all other patients, we will manage as if we are dealing with a peptic ulcer disease leading to hematemesis. Understood? Right? So that means there are two types of approaches in hematemesis. One is a ulcer hematemesis approach. Another is a variceal hematemesis approach. So in those patients, there is no varices. In all other patients where there is no varices means there is not there. Our approach will be a ulcer approach. So what is that ulcer approach? Which will be generalized for all other hematemesis is this. Now you can appreciate a patient who has a hematemesis is bleeding. So when the patient is bleeding, patient can be stable, patient can be unstable. Agreed? Patient can be stable, patient can be unstable. So patient is coming to us with hematemesis. Your patient can be stable, your patient can be unstable. What will be your immediate next step? The immediate next step in any patient of hematemesis is ABC, airway, breathing and circulation, right? And in ABC, in trauma, there also was bleeding. But in trauma, we had an issue about her spine. Here, there is no trauma. So we don't have any problem related to the spine. So to take care of the airway, we will put the patient immediately in the recovery position. What is recovery position? Left lateral position. Right? Recovery position is a left lateral position. Lateral position, any left or right, any. Right? So lateral position. So we'll put the patient in a lateral position so that the patient doesn't aspirate into the airway. Now, after putting the patient in a recovery position, usually we don't need to do anything about the B part here. There is most of the time no problem in the B. But then the approach is APC. Then we come to the C. Now, what will you do in the C? When a bleeding is happening, I made you understand already. There are two things we have to do whenever the bleeding is happening. What are those two things? Control of the bleeding and starting a replacement of the, right? So, what will we do here? Immediately, we will start IV fluid. And how will you start IV fluid? You put a two wide bore, short length cannula. Which one? 16 or 18? 16. जो सबसे बड़ी साइज मिलेगा हमें वहां पे, जो सबसे जिसका कैलिबर सबसे ज्यादा होगा गिवन चॉइसेस में वो लेंगे. अगर 14 है तो 14. Okay, so two wide bore short length cannulas, where are you going to put them? Antecubital vein. Antecubital vein, right? And what will you start immediately? You will start a balanced resuscitation. Immediately you start a balance. What is balanced resuscitation? Keeping the blood pressure around. This is balanced resuscitation is also called highest. Hypotensive or controlled resuscitation. वही सर, वही तो. Balanced or a hypotensive or a controlled resuscitation, where we have to keep the blood pressure of the patient around. So what will we start immediately? Which fluid? Ringer. Elected how much? How much? 1 liter. And along with this we'll start 1:1:1 PRBCs, platelet-rich plasma and FFPs. And along with this, very, very important, along with this, we will, because in any patient of hematemesis we know, we have to follow a ulcer approach. So we will immediately start IV proton pump infusion. We will start IV proton pump infusion. And now they say we should also add IV tranexamic acid. Right? And simultaneously what will we do? ये हमने replacement of the fluid के लिए शुरू कर दिया. जो लॉस हुआ उसका हमने शुरू कर दिया. अब हमें ये भी तो पता लगाना है कि what is the cause. So what should I do for that? What will we do? तुम लोग सारे सर्जन बनना चाहते हो लग रहा है. You should do upper GI. The investigation of choice for upper GI bleed is endoscopy. So you will do upper GI endoscopy. Now correct me if I'm wrong. Now when you do endoscopy, you will come to know that this is a ulcer bleed. Agreed? Agreed? Now listen to this, what I'm telling you. Most of the time in a peptic ulcer bleed, most of the time in peptic ulcer bleed, this treatment which you have started is a sufficient treatment. Nothing else is required. Most of the time, nothing else is required. But sometime we may need to intervene. And once we need to intervene, there are two ways of intervention. Once we need to intervene, there are two ways of intervention. One is a endoscopic intervention. Second is a surgical intervention. One is the endoscopic intervention. Second is the surgical intervention. And we prefer doing a endoscopic intervention. Right? And what we do in endoscopic intervention? We will do endoscopic coagulation with endoscopic adrenaline injection, endoscopic coagulation with endoscopic adrenaline injection to the site of the bleeding. Okay, this most of the time is sufficient if intervention is required. But if it fails, then we will do exploratory laparoscopy. Then we will do surgery, and in that surgery, we will do exploratory laparotomy with over-sewing of or under running of ulcer base. What is overswing? What we do? We take a needle with a suture and apply a running suture over the bleeding vessel. Which vessel bleeds in duodenal ulcer? Gastroduodenal artery. So we'll apply a running suture over the gastroduodenal artery and ligate. This is called overswing or underrunning of the bleeding vessel. But when are we going to do that? So imagine a question comes to you. A patient comes to you with a duodenal ulcer bleed. The initial resuscitative measures started. Endoscopic coagulation tried, but the ulcer continued to bleed. What is the next line of management? Right? And if they say initial resuscitation started and the patient continues to bleed, endoscopic coagulation with adrenaline injection. Understood? Understood? All of you? All of you? Okay, now. So this is going to be the approach in a non-variceal bleed. ये अल्सर है, आपने duodenum की posterior wall का अल्सर bleed करता है. We have an ulcer, the posterior ulcer bleeds, anterior ulcer perforates. So what will we do in exploratory laparotomy? We open duodenum. When you open duodenum, what will this be called? What ostomy? Ostomy. What ostomy? When we open duodenum, it will be laparotomy. Duodenotomy. So we open duodenum and we have done the otomy of the duodenum. Now what we do? We take a needle with a suture on and ligate this vessel, and then we close the duodenum. Huh? बिना लेप्रोटमी खोले duodenum कैसे खोलोगे? अक्कियों से गोली बड़ी मारेंगे? हाँ, एंडोस्कोपी तो पॉगलेट कर रहे हैं, आप एक जला रहे हैं उसको, ठीक है ना? जब लेप्रोटमी कर रहे हैं तो खोल रहे हैं, ठीक है ना? Okay, so this was about the ulcer bleed. Then comes if a patient chronic alcoholic, if you are provided that the patient is chronic alcoholic with those 6 things, any of those 6 things, if coming to you the hematomesis, you know that you have to follow a variceal approach, right? So chronic alcoholic, let's assume a patient comes to us with a chronic alcoholic history with gross splenomegaly with hematomesis. What will be the next step? What will you do? है तो हेमेटोमेसिस ही ना, तो एबीसी तो करेंगे, राइट? ए में क्या करेंगे? रिकवरी पोजीशन, सेम चीज, बट सी में यहां पे चेंज हो जाएगा. What change will be there in the C? We will start balanced resuscitation, that is IV fluid, 1:1:1, right? And along with this, We are not going to start proton pump inhibitor here because it's a variceal algorithm. We are considering variceal bleed here. So we will start IV octreotide. Octreotide is a somatostatin analog, right? So we'll start octreotide. If it is not available, you can use somatostatin, or you can also use terlipressin, and you can also use vasopressin, but you should avoid. And the guideline says on variceal bleed, which is not included in a ulcer bleed, that we should also add IV antibiotic here. We should also add IV antibiotic here. ठीक है, वहां पे एंटीबायोटिक की जरूरत नहीं, यहां जरूरत है. ठीक है, अब साइमल्टेनियसली क्या करेंगे हम? एंडोस्कोपी करेंगे. नाउ करेक्ट मी अगेन, this endoscopy will confirm that is a variceal bleed. Yes or no?
Yes.
But so now it's a variceal bleed, confirmed. And in variceal bleed, very important, in a ulcer bleed, this treatment was sufficient most of the time. But in variceal bleed, this treatment alone is never sufficient. So we are supposed to add endoscopic band ligation. We will apply a band, a rubber band, which ligate, kind of a ligature for a varices, so which is called endoscopic band ligation. We can also inject a sclerosant, which is called sclerotherapy. We can also inject a sclerosant in a vessel, but preferred is band ligation. Preferred is a band ligation. If this fails to control this bleeding, if this fails to control this bleeding, then the guideline says reapply, try to reapply band endoscopically. Try to get lucky second time. Okay, and if second time also you fail, then you are left with no choice to do tips. What is tips? Suno. What is tips? Because vasopressin can lead to severe vasoconstriction, which can lead to mesenteric ischemia also. Okay. Now, very important point. Please understand this point again. This can be again a question in exam. Your patient is bleeding here, and TIPS is not a procedure which is available over the counter. आपने बोला और चालू हो गया. TIPS is a very high-end thing. आपको जुगुलर वेन से जाना है, यहाँ से जुगुलर वेन से एंटर होके हिपैटिक आईवीसी से एंटर होके हिपैटिक वेन से एंटर होके लिवर के अंदर हिपैटिक वेन और पोर्टल वेन के बीच में शंट डालना है. सब इंटरवेंशन रेडियोलॉजी के थ्रू हो रहा है. So this is not a very simple procedure or over the counter procedure कि आपने बोला और हो गया. It takes time, and your patient is bleeding here, right? You can't have this waiting for this procedure and your patient is bleeding. Your patient may die in wait of the procedure itself. So it takes time. TIPS is not something which is going to be available as a. It will take some time. So till the time you are arranging things for TIPS, the next thing we have to do is TIPS. But you have to arrange things for TIPS. Since the time you are arranging things for tips, you have to somehow control the bleeding. And how will you control that bleeding? बैंड से तो हो नहीं रही ना. रुक जाओ यार, मैं बताऊं. Sengs taken, Blackmore tube. We will put a Sengs taken, Blackmore tube. अब ये क्या होता है? ये होता है. क्या बुला दो? बलून है तो बुलाना ही है. बलून तो बुलाते ही है. हाँ बिल्कुल, एब्सोल्युटली राइट. सो देयर इज अ ट्यूब लाइक दिस. एक ट्यूब आती है ऐसे. इस ट्यूब में दो बैलून होते हैं. एक होता है स्टमक बैलून, एक होता है ईसोफेजियल बैलून. इन दोनों बैलून्स को बुलाना है, राइट? दिस ईसोफेजियल बैलून will be inflated to a pressure of 40 mm of mercury, and this is inflated with air. Stomach balloon is inflated with air, about 300 ml air. Esophageal balloon का pressure होगा 40 mm mercury, and stomach balloon is inflated. We don't need to think about the pressure here. We just have to inflate to a 300 ml of air, right? Now what this esophageal balloon is going to do, it will compress the bleeding point. It will compress the bleeding point till the time you are arranging things for tips. This is called Sengs taken, Blackmore tube. Okay, and the most common early complication of tips is encephalopathy. Most common late complication is stenosis. A very commonly asked question. Most common early complication of tips is encephalopathy. Most common late complication is stenosis. Right? Now answer this question. Let's see whether you have understood the concept or not. Chronic alcoholic with mild splenomegaly comes to you with hematemesis. What is the next line of management? IV pantoprazole, IV propranolol, IV octreotide, IV vasopressin. IV pantoprazole, IV propranolol, IV octreotide, IV vasopressin. A, B, C, D. A chronic alcoholic with mild splenomegaly comes to you with hematemesis. What is the next line of answer? A, B, C, D. A, C, A. Chronic alcoholic with gross splenomegaly. Next question. Chronic alcoholic comes to you with gross hematemesis. What is the next line of management? चॉइसेस यही है। प्रोपेनोलोल कब था? अच्छा, okay, now another question. Chronic alcoholic with gross splenomegaly comes to you with hematemesis.
C.
Comes to you with hematemesis, found to have a variceal bleed. Found to have a variceal bleed. एग्जाम में भी यही होगा, देख, जल्दबाजी नहीं करनी है। जो क्वेश्चन आता है बहुत अच्छी बात है, आता है, अगर आते हुए गलत हो गया ना तो उससे खराब नहीं हो सकता कुछ। जो नहीं आता था तो उसमें तो इंकी पुंकी पौंकी करना ही था। So chronic alcoholic with gross splenomegaly comes to you with hematemesis, found to have a variceal bleed. Which of the following drug should be avoided? A, B, C, D. Yes, sir? Yes. Good. So then comes Mallory, Wiss-Tier and Verhoeven's perforation. Mallory, Wiss-Tier and Verhoeven's perforation. Now, both these conditions are actually going to happen in a similar kind of situation, but there is still a difference. Both these conditions, and we have to make out a difference on the basis of the clinical profile provided also in a given question. Both these conditions are seen commonly in elderlies after alcohol intake on heavy meals, with heavy meals. Both these conditions are happening because of a severe bout of vomiting. Both these conditions are happening because of a severe bout of vomiting. The basic difference is, in a Mallory Wiss, there is a longitudinal tear happens involving mucosa and submucosa. In Verhoeven's, there is through and through perforation happens. So the basic difference is, एक में tear हो रहा है, एक में पूरी की पूरी wall खुल जा रही है. But दोनों conditions are happening due to severe bout of vomiting. So you can appreciate the bout of vomiting in Verhoeven's is going to be much severe than what we had it in a Mallory Wiss, because it depends on how severe is the vomiting, the injury, the trauma is according. How will a patient of Mallory Wiss tear is going to present? Patient presents with hematemesis. Patient present with hematemesis and melena. How will a patient of Verhoeven's perforation going to present? Severe hematemesis. ये भी ठीक है. Meckler's triad. Verhoeven's is a perforation of the esophagus. right? And the most common site of this tear checked in exam is gastric cardia. Most common site of this malarious tear, it starts from a gastroesophageal junction and reaches gastric cardia. So gastric cardia is the most common site. Most common site of Barhovi's perforation is lower esophagus. Lower esophagus. Now, what will be the management of a malarious tear? Can you tell me? In any hematemesis other than the variceal bleed, the same algorithm will run. IV fluid, IV pentobazole and tranexamic acid also. And most of the time in malarious tear, this treatment is sufficient. It's not a very severe bleeding. It's kind of a mild bleeding. So most of the time it is sufficient. If it fails to control a bleeding, then we do endoscopic coagulation. If this also fails, then we do exploratory laparotomy with overswing of tear side. What will we do in Barhovi's perforation? Can anyone tell me? पहले डायरेक्ट वही कर देंगे, बड़ी जल्दी है यार। खोल के सूचर करेंगे। Initially we'll do nilparorally, IV fluid, IV antibiotic and IV anti-inflammatory drugs. Then if the patient comes to us in less than 24 hours, we'll do primary repair with butt dressing. If the patient comes to us in more than 24 hours, we will do. Okay? So this is how we go about in a various causes of hematemesis. चलें आगे। Starts from gastroesophageal junction. Why will do exactly like a esophageal perforation? Because it's a esophageal perforation. So why will we not do exactly like a esophageal perforation? When it's a esophageal perforation, we have to do it like esophageal perforation. Now, then comes boom. The most common cause of gastric outlet obstruction is earlier was peptic ulcer disease. Now it is carcinoma stomach. But we are talking about gastric outlet obstruction due to peptic ulcer disease. We are talking about gastric outlet obstruction due to peptic ulcer disease, but you should know that the most common cause of gastric outlet obstruction is carcinoma stomach now. But how are we going to go about in a gastric outlet obstruction due to peptic ulcer disease? We are talking about here. Now, how will a patient of gastric outlet obstruction going to present to us? The most common presentation of these patient will be vomiting, non-bilious vomiting, 2 to 3 hours after meals. Patient will come to us with a complaint of vomiting happening 2 to 3 hours after meal. The undigested food comes out in this vomitus. Undigested food will come out in this vomitus. Patient will also have epigastric discomfort. Patient will also have a epigastric discomfort. On examination of these patients, you will find epigastric fullness. You will find epigastric fullness and very classical sign also, which is called succussion splash. Now, what is the succussion splash? When you put a bell of the stethoscope on the epigastrium of the patient, and when you shake the patient, shake it, baby. So when you shake the patient, you will get a gurgling sound. So on shaking the patient, on putting a bell of the stethoscope in the epigastric region, if you get a gurgling sound, it is called succussion splash. And investigation of choice. Now, before we come to the investigation of choice, we should know that there is a classical, very important, electrolyte disturbance in these patients. What is that classical electrolyte disturbance? That is very important, and that is hypochloremic, hypokalemic, kalemic, metabolic, alkalosis. And very, very important point to note, in a long-standing cases of this condition, you will get paradoxical aciduria also. In long-standing cases of this condition, you will get a paradoxical aciduria also. Investigation of choice for this condition is upper GI endoscopy. And very, very important, the first line of management here is correction of electrolyte disturbance. Correction of electrolyte disturbance. And the treatment of choice for this condition, if asked, it is pneumatic dilatation. But if you are asked what is the best treatment for this condition, it is truncal vagotomy with enterectomy. If not in your choice, then truncal vagotomy with gastrojejunostomy. So this is about gastric outlet obstruction. Gastrojejnostomy. What suture are you going to use for gastrojejnostomy? Running. What suture are you going to use when running? Very good. स्ट्रेंथन करना है, लटकता है उस पे। क्यों स्ट्रेंथन क्यों करना है गैस्ट्रोजिनोस्टमी को? गैस्ट्रोजिनोस्टमी इंटेस्टाइनल एनास्मोसिस है। TDS. And how will you do that repair? Extra mucosal repair. What is the name of that repair? Matheson's repair. What needle are you going to use? Which needle? Round body needle. पीडीएस और वाइक्रिल में क्या फर्क है पूछता है, बताओ बताओ इनको क्या फर्क है। पीडीएस के बराबर ही हुआ। एक सूचर एब्जॉर्ब हो रहा है 3 मंथ्स में, एक सूचर एब्जॉर्ब हो रहा है 180 डेज में, सेम ही तो है। नहीं डबल है बट सेम ही है। और क्या फर्क है वाइक्रिल और पीडीएस में, कौन बताएगा? पीडीएस क्या है? नॉन ब्रेडेड है, वाइक्रिल इज ब्रेडेड। चले आगे। देन कम्स infantile hypertrophic pyloric stenosis. Infantile hypertrophic pyloric stenosis, which was earlier called congenital hypertrophic pyloric stenosis. Infantile hypertrophic pyloric stenosis, which was earlier called congenital hypertrophic pyloric stenosis. It is an autosomal dominant disorder. Important point. It's an autosomal dominant disorder seen in firstborn infantile hypertrophic pyloric stenosis, which was earlier called congenital hypertrophic pyloric stenosis. Infantile or idiopathic, both can be used, but commonly now we see infantile. Firstborn male child, seen in firstborn male child, and the most common age of presentation in this is 3rd to 4th week of life. 3rd to 4th week of life. And how does these newborn presents? The most common presentation here is non-bilious, initially projectile, then non-projectile vomiting. Non-bilious, initially projectile, then non-projectile vomiting. And very important point further to note in this, After this vomiting, these newborns have a voracious appetite. After this vomiting, they feel very hungry. So they have a voracious appetite. On examination of these newborns, a mother will come to you with a classical presentation herself, that she will say that she can feel a olive shaped lump in the epigastric region, and she will also tell you that she can see a wave of peristalsis going from left to right. She will also tell you that I can see a wave of peristalsis going from left to right. And this itself actually confirms the diagnosis, but then we have to actually document it. So for documentation, the investigation of choice for this is ultrasound. The investigation of choice for this condition is ultrasound. And very important point which they keep asking in your exam, what is the best time to palpate this lump? The best time is, if after vomiting is not in your choice, then it is during feeding. And in these newborns also, important, there is a classical electrolyte disturbance. What is that classical electrolyte disturbance? Hypochloremic, hypokalemic, metabolic alkalosis. And if this problem is long standing, here also there will be paradoxical aciduria. And on X-ray abdomen of these newborns, you may get a single bubble sign also. The first line of management in them also is correction of electrolyte disturbance. And then the treatment of choices, Ramsted's, pyloro, myotomy. Otomy, you have to divide the muscle. Then comes carcinoma, चले आगे, कार्सिनोमा स्टमक, नहीं, carcinoma stomach, most common site, most common type. क्यों? खाना पहले ग्रेटर टेम्परेचर में जाता है। मोस्ट कॉमन साइट ऑफ कार्सिनोमा स्टमक, देखो दिल से नहीं सोचना, खाना ग्रेटर टेम्परेचर में जाता है तो स्टमक कैंसर वहां होगा, ऐसे कैसे? मोस्ट कॉमन साइट इज, as per the latest, it is proximal stomach near GE junction. But please be very careful if they ask you what is the most common site of carcinoma stomach in Asian population, specifically Asian population. If they ask you, then it will be pre-pyloric region, that is antrum. Most common type is adenocarcinoma. Now, some of the risk factors are important here, and we should remember these risk factors. Can you tell me what is the most important risk factor for carcinoma stomach? H. pylori. The other risk factors which are important for our exams are pernicious anemia. And please be very careful, in pernicious anemia, the most common site is fundus. Then lack of refrigeration, important. Smoked food. So tell your PG to have a fridge in your PG stomach. Smoked food. What is smoked food? Barbecue food. Epstein-Barr virus. Epstein-Barr virus. Then previous stomach surgeries. Remember, I made you understand that also. How stomach surgery has a risk of carcinoma stomach.
Yes.
Right? So, previous stomach surgeries have a risk of carcinoma stomach. Then, chronic atrophic gastritis. And blood group? A. CAA. Blood group A. So these are the important risk factors which we have to keep it in mind. Most common presentation. Most common presentation? Pain where? Pain epigastric region. Patient can also come to us with loss of appetite or weight loss. Patient can also come to us with features of goo. Patient can also come to us with ascites. Patient can also come to us with jaundice. Patient can also come to us with left supraclavicular lymph node enlargement. Left supraclavicular lymph node enlargement. This left supraclavicular lymph node is also called Burkow's node, and this enlargement is also called Trousier's sign. Patient can also come to us with migratory superficial thrombophlebitis, which is also called Trousier's syndrome. Patient can also come to us with Sister Mary Joseph nodule. What is this Sister Mary Joseph nodule? It's an umbilical nodule. Due to, why does this nodule develop? Due to hepatoduodenal ligament spread. Superficial. Patient can also come to us with Krukenberg tumor. What is Krukenberg tumor? It is a bilateral ovarian metastasis. Why does this happen? This happens due to a question asked, transperitoneal spread. Patient can also come to us with Blummer shell. What is Blummer shell? Nodularity at pouch of Douglas. Nodularity at pouch of Douglas, and this is also due to transperitoneal spread. What is the investigation of choice? Endoscopy. एंडोस्कोपी करेंगे तो बायोप्सी तो लेंगे ही, वो घूमने थोड़ी जा रहे हैं कि एक बार देख के आएंगे, अगली बार बायोप्सी के लिए आएंगे कि अच्छा देख लिया, अगली बार आता हूँ, क्योंकि बायोप्सी तो लिखा नहीं था. Investigation of choice is endoscopy. Investigation of choice for staging here also is PET-CT. If not in the choice, then CT. Now, there are two classifications for carcinoma stomach which we have to know. One is a Borman's classification. Another is a Lawrence classification. We don't need to go into the detail of Borman's, but we just need to know in Borman's type 4. Just type 4 is important for you. Type 4 is diffuse infiltrating type, and limitus plastica, that is leather bottle stomach, belongs to this. Diffuse infiltrating type is type 4. Limitus plastica, that is leather bottle stomach, belongs to this. अभी तक कैलीग्राफी में मास्टरी नहीं हुई क्या? हो गई? इतना बना बना के तो लिखता हूँ. Lawrence classification is the classification which we should know in detail about. Leather bottle stomach is a consistency of the stomach which happens because of this type of diffuse infiltration. Lawrence classification divides carcinoma stomach into leather bottle stomach, limitus plastica. Just remember, leather bottle stomach is a type of carcinoma stomach which is a diffuse infiltrating type, where the stomach assumes a consistency of a leather bottle. Leather bottle जो डेजर्ट्स में लोग कैरी करते हैं ना, वैसे कैमल वाला. कैसा, हमें क्या पता, हम थोड़ी डेजर्ट गए करते होंगे. Lawrence classification. In Lawrence, we have intestinal type and we have diffuse type. Lawrence classification. Can we proceed now?
Yes, sir.
Lawrence classification divides carcinoma stomach into intestinal and diffuse type. More common is intestinal type. Intestinal type is associated with H. pylori. Intestinal type is associated with H. pylori. Diffuse type is associated with family history. Blood group, क्या बात है, आगे. Blood group A. This is also associated with chronic, atrophic, atrophic gastritis. And important point in these two types of carcinoma stomach, in this type, there is more of a hematogenous spread. It more commonly spread through a hematogenous route. And this type usually has a transmural or lymphatic or transperitoneal spread. This is seen in young individuals. This is seen in elderly. These are the important points we need to know about this intestinal and a diffuse type. Then comes management. So that means if they ask you in which type of carcinoma stomach, you commonly get a Krukenberg tumor. C stomach. Which type? Diffuse type. Management. In management of carcinoma stomach, we have option of surgery, we have option of chemo, we have option of radio. You have option of chemo, you have option of surgery, you have option of radio. And surgery here also is the main modality. These are the adjuncts. Now again, what I'm going to do, I will give you a very simple way of understanding the management. With this, you can answer any question. Now what is that? Let's see. There is something called advanced carcinoma stomach. Just remember this. What is advanced carcinoma stomach? When there is a distant metastasis. Once there is a distant metastasis, it is advanced. Once there is a malignant ascites, it is considered advanced. And once the D3 lymph nodes are enlarged, means D2 we know? I hope so.
Yes.
D2 we know? Celiac, hepatic, splenic. D3 is lymph node along IVC or aorta. Lymph node along IVC or aorta. So if these are there, any of these are there, it is considered advanced carcinoma stomach. Okay. And what is our primary objective in advanced malignancies? Quality of life. So we are supposed to do palliation of symptoms. We are supposed to do palliation of symptoms, and at the same time we should try to improve the quality, the survival also. So we will give chemotherapy. But how will you palliate? What symptom we have to palliate? What is the problem in these patients? The problem are two. One is the pain. The most common presentation of them is pain. So one problem they will have is a pain, which you have to relieve. So we will take care of the pain relief, and we are also supposed to take care of goo. गू क्या होता है गू में? गैस्ट्रिक आउटलेट ऑब्स्ट्रक्शन होगा तो वॉमिटिंग ही तो हो रहा है. So how will you palliate gastric outlet obstruction? Now tell me. गैस्ट्रिक आउटलेट ऑब्स्ट्रक्शन है पेशेंट को, हर जगह ट्यूब डाल देंगे? कहाँ डालेंगे ये तो बताओ. ये हो रखा है, ट्यूब डाल देंगे. ट्यूब ईसोफेगस में भी डलती है, ट्यूब ट्रेकिया में भी डलती है, ट्यूब एब्डोमेन में भी डलती है, ट्यूब रेक्टम में भी डलती है, हर जगह डलती है. स्टमक में. So how will we palliate gastric outlet obstruction here? Either we can do stenting, or we can do this. What will this be called? You ruin by it. You build up 2 है, you build up 1 है. ये सिंपल गैस्ट्रोजिस्टोस्टमी है. ये ना तो बिलरॉथ 1 है, ना ये बिलरॉथ 2 है, ना रूएनवाई है. हमने स्टमक को निकाला क्या? हमने सिर्फ स्टमक को जेजनम से जोड़ दिया. So this is just a simple gastrojejunostomy. This is not Billroth 1, Billroth 2, रूएनवाई gastrojejunostomy जब हम करते हैं तो उसका मतलब स्टमक को निकालने के बाद हो रही है वो बात. यहाँ पे हमने स्टमक में कुछ नहीं किया. ठीक है. बट मेजरली आपकी प्रॉब्लम तो सॉल्व हो रही है, आ तो पाएगा आप। शौक बड़ी चीज है। So you should do gastrojejunosmy or stenting. Okay, now for rest all, this is advanced, ये advanced है। बाकी सब में your answer should be radical gastrectomy followed by plus minus chemotherapy. बाकी सब में your answer is radical gastrectomy followed by plus minus chemotherapy. They will not check you when to give chemotherapy. They will just check you this on this. ठीक है? So this was about carcinoma stomach. Then comes GIST. What is GIST? Very good. Gastrointestinal stromal tumor. GIST is gastrointestinal stromal tumor. Now, what is this GIST? Let's understand. This is a mesenchymal tumor. This GIST is a mesenchymal tumor, and this tumor resembles muscle tumor, but it is not a muscle tumor. It resembles leiomyomas, muscle tumor, but it is not a muscle tumor. So how is it different from a muscle tumor? This tumor has a very classical mutation on it, which muscle tumor don't have. And what is that mutation? They have presence of c-KIT mutation. These are the only tumors in the body which have on them a c-KIT mutation. They have CD34 and CD117 as a marker on them, which no muscle tumor has. And they also have now found to have a DOG1 mutation also. What is DOG1? Discovered on GIST1. This type of mutation is only seen in GIST. So if they ask you what is the most specific mutation in a GIST, answer is DOG1. If not in your choice, then CD117. The most specific mutation in GIST is DOG1. If not there in your choice, then it is CD117. Now, most common site of GIST in GIT, a very commonly asked question. The most common site of GIST in GIT is stomach. Most common site of GIST in GIT is stomach, and stomach GIST arises from, very commonly asked question, stomach GIST arises from interstitial cells of Cajal. This GIST in stomach arises from the interstitial cells of Cajal, and these are the pacemaker cells. Stomach GIST arises from interstitial cells of Cajal, and these are pacemaker cells present in the muscular layer of stomach. Now, most common presentation. Most common presentation of a gist of stomach is bleeding. Patient here also can present with goo. Patient here can also present with goo, and patient can also be asymptomatic, can present with an asymptomatic mass also. Patient can also present to us with an asymptomatic mass also. सिर्फ मास है, कोई कंप्लेंट नहीं है, सिर्फ स्वेलिंग है. Investigation of choice for gist of stomach is CT scan, while gold standard is endoscopic ultrasound guided biopsy. Now, in treatment, once the gist is symptomatic, in treatment of a gist, once the gist is symptomatic, or even if it is asymptomatic, but size more than 2 centimeter, in either of these situations, your answer should be wide excision with 2 centimeter margin. But once the patient is asymptomatic, having a size of less than 2 centimeter, your answer as per the latest is imatinib. What is imatinib? It's a tyrosine kinase inhibitor. It's a tyrosine kinase inhibitor. Gist has a tendency of recurrence. Gist has a tendency of recurrence. Please note this important point. If you are asked what is the investigation of choice for recurrent gist, please be careful. If recurrent word is there, your answer should change to PET CT. If PET and CT are in separate choice, then PET scan. And treatment of choice for recurrent gist is always wide excision followed by imatinib. Always. And this is all about our discussion on stomach. In asymptomatic less than 2 centimeter, we just give imatinib. We do wide excision with 2 centimeter margin. If the margin is positive, then only we give imatinib.
So, wide excision plus imatinib.
Wide excision followed by imatinib. क्या करें बताओ? Imatinib. So should we continue? Try करें. How many of you want me to end the class? How many of you want me to end the class? बात नहीं करें. 12 बजे भी चलेगा.